Hello and welcome to today's webinar, Expanded Medicare Advantage Supplemental Benefits, offering flexibility to support high-need Medicare beneficiaries, hosted by the Medicare Playbook through support from the Seven Foundation Collaborative. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question-answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Michelle Soper, Vice President for Integrated Care at the Center for Healthcare Strategies.
Thank you, Travis. And hello, everyone. I'm delighted to kick off this webinar today. Again, my name is Michelle Soper, and I'm the Vice President of Integrated Care at the Center for Healthcare Strategies. I want to begin by thanking the Seven Foundation Collaborative as well for supporting the Better Care Playbook and this webinar, as well as three specific foundations within that collaborative: Arnold Ventures, the Commonwealth Fund, and the SCAN Foundation for supporting the research that you'll hear about today. Next. Thank you. So here's the agenda, and actually I will ask you to go to the next slide, please, as well. I'm going to go through the agenda as I introduce today's speakers at the same time. So after a brief introduction that I'll provide about Medicare Advantage supplemental benefits, I'm going to turn it to Narda Ipakshi, who is a senior consultant with Health Management Associates. She will discuss HMA's research about the types of supplemental benefits that Medicare Advantage plans offered in 2020, some opportunities and barriers to health plans adopting new expanded supplemental benefits. Then we'll turn to Matt Kazan, who is a principal at Avalier, who will share their research findings on plan adoption of supplemental benefits between 2018 and 2020, and also talk about the potential impact that new expanded benefit offerings could have on Medicare beneficiary with high risk factors. Lastly, we'll turn to Tyler Cromer, who is an ATI advisory. She will take a look into that was released today, that offers a roadmap to guide plans offering expanded supplemental benefits, as well as some policy insights and core implementing principles that a diverse group of stakeholders developed. And last but not least, Dr. Sachin Jain, who is President and CEO of SCAN Group and Health Plan, will offer some reactions to the research presented, as well as describe the SCAN Health Plan strategy for adopting expanded supplemental benefits for its Medicare members. And then we'll wrap up with some time for Q&A. Next slide, please. Thank you. So I wanted to just quickly tell you about the Better Care Playbook for those of you who are unfamiliar. The Better Care Playbook is a robust online resource center that provides healthcare stakeholders with the best and latest knowledge on evidence-based or promising practices for people with complex health and social needs. As I just noted, the playbook is supported by the Seven Foundation Collaborative, which as a group seeks to help healthcare organizations adopt evidence-based interventions to improve outcomes and lower overall costs of care for individuals with complex needs. And the Center for Healthcare Strategies, where I work, is a nonprofit health policy resource center that supports innovations in care delivery and improvements in healthcare for low-income Americans. We lead the playbook work in addition to working with states, health plans, providers, community-based organizations, and federal policymakers on programs that integrate services for people with complex needs, advance delivery system and payment reforms, and build Medicaid and cross-sector leadership capacity. Next slide, please. So just to give you a quick overview of Medicare Advantage supplemental benefits before we dive into the latest research, Medicare Advantage plans cover all hospital and medical benefits provided under original or fee-for-service Medicare. Outside of Medicare covered services, plans can offer supplemental benefits, which is an item or service not covered by original Medicare, and that traditionally must be primarily health related. So this means that an item or service prevents, cures, or diminishes an illness or injury. Common examples of supplemental benefits include vision, hearing, dental, medical transportation, support with over-the-counter medications, among several other examples. Medicare Advantage plans pay for supplemental benefits using rebate dollars. And these funds are generated from the difference between a plan's bid and its annual bid amount and the our national or regional benchmark rate. The percentage of the rebate that's kept by plan varies based on its CMS star rating. So therefore, the plans with the highest ratings or the highest quality scores retain a larger proportion of their rebate. Next slide, please. Increasing recognition of the impact of functional needs and social determinants of health on health and health outcomes led CMS and Congress to identify new pathways that Medicare Advantage organizations can address these needs. First, in 2019, CMS announced an expansion of the definition for primarily health-related that was further clarified in guidance. The expanded definition allows Medicare Advantage plans to offer supplemental benefits that diagnose, compensate for physical impairments, act to improve functional or psychological impact of injuries or health conditions, or otherwise reduce avoidable emergency or healthcare utilization. So these can include benefits that support what are traditionally known as long-term services and supports services or needs, and those are listed, examples of those are listed on the slide. Next, the Bipartisan Budget Act of 2018 called for a further expansion of these through creation of special supplemental benefits for the chronically ill. These benefits do not need to be primarily health related, can address social determinants of health needs, as long as they have a reasonable expectation to improve or maintain the health or overall function of a chronically ill enrollee. To offer SSBCI, plans need to define specific chronic conditions such as diabetes, asthma, congestive heart failure, among several other examples, and design specific benefits to target these specific individuals. Plans began offering SSBCI in 2020. Then lastly, and traditionally, Medicare Advantage plans had to offer supplemental benefits to any members who were eligible for them in a service area. However, beginning in 2019, CMS relaxed this requirement to allow Medicare Advantage plans to offer different supplemental benefits to members with specific diagnosed medical conditions, as long as all individuals with that condition are offered the same benefits. In addition, the Balanced Budget Act of 2018 allowed CMS to waive the uniformity requirement beginning in 2020 for SSBCI. And with that, I am happy to turn it over to the first presentation, and we'll hear from Narda at Health Management Associates.
Good afternoon, everyone. Thank you for joining today. Next slide, please. So our research was really divided into two phases, thinking about, wanting to really understand the new flexibilities available and how plans and the health policy community were responding to them. The first was really looking at, based on the data, just the overall adoption and availability of supplemental benefits in 2020 across the various flexibility types that Michelle just mentioned. And then based on what we saw, we conducted interviews with Medicare Advantage organizations, beneficiary advocates, and service providers to understand what contributed to adoption or a decision not to adopt the benefit, as well as what contributed to the factors in terms of selecting the actual benefits that they offered. We also wanted to get an understanding from beneficiary advocates, service providers, and health plans, when those benefits were offered, what were some of the early lessons learned from their implementation? Next slide, please. So I think Michelle really covered this well. I think the only other supplemental benefit flexibility that we incorporated in our analysis was the value-based insurance design model. This one's a little bit unique in that, plans need to apply and get approved for this flexibility, but they can offer tailored cost sharing or supplemental benefits for enrollees based on condition or socioeconomic status, in this particular case, dual eligibility status or low income subsidy status. Just for purposes of, as we go out throughout the presentation, rather than referring to all 4 of the flexibilities uniquely when I'm talking about them in sum, I'll refer to them as flexible benefits, just to save everyone several hours. But flexible benefits is the term that I'll use when we're talking about all 4. Next slide, please. So overall, and again, this is part of our initial analysis, what we saw in terms of the 2020 MA benefit offerings and enrollment data, we saw that adoption of an enrollment in plans offering 1 or more of the new supplemental benefit flexibilities is relatively low, with only about 19% of individuals enrolled in plans offering those benefits. Now, that's not entirely surprising based on what we've seen in terms of past precedent and adoption of new benefit flexibilities. We saw similar rates of adoption for new benefits such as remote monitoring technologies when those were first made available. It generally takes time. Some plans enter the market early, others like to wait and learn. But given all the excitement that we saw around these particular benefits, what we're seeing is that, at least for 2020, relatively low. I do want to mention that these numbers are based on the bids that plans submitted in 2019 for the 2020 plan year. So this was all pre-COVID. CMS did encourage plans to make use of mid-year benefit enhancements, and we did hear that several plans did elect to expand flexible benefit offerings as a result. We also expect that, as I mentioned, that adoption will increase over time. So as plans get a better handle on the benefits, get a better understanding of if and how they can help reduce total cost of care. So that's something we're going to be continuing to monitor. We don't have detailed data on all 4 flexibility types for 2021 yet. We do have some data on the primarily health-related benefits indicating that there's a significant uptake. And CMS has relayed in press releases that there's been an increase in all 4 flexibility types. I know that ATI will be getting a little bit more into that, so I'll let Tyler speak more about that. But in terms of 2020, we also saw a lot of variability in the type of flexibility adopted. So we see the highest in expanded primarily health-related benefits, followed by uniform flexibility, and then SSBCI and VBID. And we also found, based on the data, that a significant proportion of the offerings with new flexibilities are special needs plans, and particularly DSNPs. And that raises some additional questions regarding access, because you think about, not every Medicare eligible individual is able to enroll in a special need plan. And some of these flexibilities or new benefits were available to DSNPs prior to the expansion of the flexibilities. Next slide, please. So we got a little bit on this in the last slide, but we see from the data that organizations seem to have very different strategies when it comes to adoption of the new benefit flexibilities. So the dominant player for primarily health-related and SSBCI we see is Anthem. Humana accounts for almost half of enrollment in plans offering VBID, and none of the top 5 sponsors have really dug into uniform flexibility. For that one in particular, it looks like the major players are some of the provider-sponsored plans. And these are some of the things that we really hope to get to dig into more during our interview phase. So we'll talk a little bit more about that later. Next slide, please. We also saw a lot of geographic variability in terms of which benefit flexibilities were adopted where. So there are lots of parts of the country where there are no offerings at all available. Many of those coincide with areas where there's not a lot of MA penetration, so that's expected. But even among areas where there is high MA enrollment, we still see a lot of variability. Next slide, please. So after looking at the data, we really wanted to understand from the stakeholders implementing the benefits, delivering the benefits, and using the benefits, what the value is that they provide, whether or not they're effective as a tool to contain costs, to improve outcomes, further engage beneficiaries, and address unmet health and social needs, as well as what some of the challenges and lessons learned were during implementation. So as I mentioned, we interviewed beneficiary advocates, we interviewed Medicare Advantage plans, as well as service providers to get answers to some of those questions. The first piece that we assessed is really contributing with the factors that contributed to an MA plan's determination to offer or not offer the flexible benefits and how they chose the benefits that they did. So all of the organizations that we interviewed indicated that 2020, which is the first year that all 4 flexibilities were available, really served as a period for learning, for experimentation, evidence gathering, and really talked about a need for more data on which flexible benefits would be most effective in terms of addressing health outcomes and costs. So given that lack of concrete data, plans generally evaluated their decision making around one or more of 3 factors. The first was around an identified member need. So plans have indicated that they're always looking for strategies to address the needs of their members, particularly those with complex health conditions. And they've been collecting over time through member surveys, through reviews of grievances and appeals, focus groups, and external research, information to understand not only what current benefits members are satisfied or unsatisfied with, but also to learn about what additional benefits could be made available that would benefit them most. They also looked at upfront costs. So obviously some benefits are more costly than others to provide, either because of the nature of the benefit or anticipated utilization. And given that plans are not given additional funding to offer these benefits, as Michelle mentioned, they're funded through rebate dollars. So plans really had to assess the initial cost of the benefit, and that really informed their decision. Of all the plans that we talked to that offered a benefit in 2020, not a single organization was willing to reduce any existing benefits offered, such as premium reductions, reductions in cost sharing, or some of the more traditional supplemental benefits like your vision, hearing, dental, in order to offer these these flexible benefits. Some indicated that they did have to make trade-offs within the new flexible benefits that they wanted to offer, but they really wanted to maintain the existing offerings that they were offering their members. The last dimension that the plans really looked at was around marketing and innovation. So for some plans, and these plans indicated that they had more resources to work with, for these plans, they indicated that the risks of offering the benefit were overcome by the perceived benefit of being able to be seen as a market leader or market innovator and really responding to the needs of their members in their community. Nearly every MA organization that we talked to also indicated that they either offered or considered offering either meals, transportation, or social isolation benefits in 2020. And that was largely because they indicated that the evidence base, while still relatively small, was much larger for these benefits as opposed to some of the other potential benefits they would be offering. And for social isolation, even though there isn't necessarily as robust of an evidence base for that, some plans indicated that they use the social isolation benefit as an opportunity to serve as that data gathering exercise. So for example, the social isolation provider would visit with the member and ask questions about food security or whether or not that individual had reliable transportation, and that served as a sort of data gathering exercise. We also saw that benefits offered significantly among the plans that offered them. So for example, one health plan offered in-home services and supports, which was 124 hours of services annually, while another organization, the limit was only 40. Another MA plan offered food and produce benefit, and that included monthly meal deliveries. And another organization's meal benefit was an allowance or card that could be used towards the purchase of those items at approved locations. And then the last thing that really informed the benefit offerings in 2020 was the availability and presence of service providers. So obviously, plans could only offer benefits in areas where there was a service provider that could deliver the benefit. So if they wanted to offer transportation, but there was no transportation vendor, that limited where the plan could offer it in 2020. So that also seemed to inform some of the decision making. Plans also seem to have very different approaches in terms of the types of organizations that they wanted to partner with. So some organizations really preferred to work with an organization that had a national brand, national presence. That to them was an indication of trust and reputation. Others really preferred working with local community-based organizations that had really deep-rooted ties in the community. Next slide, please. So after looking at the factors driving the decision to offer or not offer benefits and which benefits were offered, we really wanted to understand the challenges, best practices, lessons learned from implementation. So this is really where we gather the insights from not just plans, but also beneficiary advocates and service providers. So the first one I think we've talked about quite a bit, so we won't go into it, but obviously, again, the limited evidence base really makes it a challenge to evaluate whether and how to provide the new benefits and to what scale. We also heard that having multiple supplemental benefit pathways creates quite a bit of confusion and administrative burden. For the most part, the plans that we talked to when they were electing to offer a new benefit, they first decided the benefit that they wanted to offer, the population that they wanted to target, and then figured out later which flexibility provided them an opportunity to offer that benefit. It was very rare to hear, at least in our interviews, that the flexibility policy is what drove the offering of the benefit. And then even when the benefits are available, communicating them to beneficiaries served as a challenge. So, the marketing and education requirements vary by flexibility type. So, for example, those participating in VBID, there's a marketing prohibition. And then the eligibility criteria also varies, not just by flexibility type, but also by specific benefit in some cases. Plans talked a lot about the efforts that they undertook in order to train care managers, train agents and brokers, and other staff. But beneficiary advocates that we talked to indicated that the communication was not really sufficient. And when it was conducted, it was really difficult to understand. And we talked a little bit about the scope of benefits varying across plans. That was another big area of concern for beneficiary advocates. And they really felt that made it difficult for beneficiaries to understand which specific benefits are available in their plan, as well as the criteria for eligibility. We also heard that the current flexibility policies don't necessarily allow plans to reach those beneficiaries that would benefit the most. So, right now it's very much focused on clinical criteria. All stakeholders that we interviewed suggested that these benefits would be much more impactful if plans were able to offer them based on socioeconomic or environmental needs, such as living in a rural area or another under-resourced area. These benefits are new to plans and social service providers. So for many of these providers, this is their first experience with the MA program or even Medicare. So they didn't typically have systems in place to take service requests, to submit claims, maintain service records. They're not familiar with things like HIPAA compliance or the audit process, or even just the Medicare Advantage plan year cycle. So service providers reported having to make a lot of upfront investments in order to get up to speed. And even then, they indicated there was a pretty steep learning curve until things were able to start running smoothly. And then we also heard that there maybe wasn't necessarily a whole lot of involvement from the beneficiary community in the development and design of a lot of these benefits, particularly for certain high need subpopulations like individuals with disabilities or those with certain chronic conditions that were being targeted. Many plans did report taking on really targeted efforts to conduct focus groups and surveys, et cetera, but that was really led at the plan level as opposed to the overarching policy level. I know that when we conducted our outreach, all the beneficiary advocates, including those subpopulations that I just mentioned, were supportive of the flexible benefit policies in theory, but really had a challenge communicating whether and how the policies impacted the specific subpopulations they were representing. And then last but not least, we heard from many interviewees a concern that these benefits right now are limited just to those in the MA program, which means that 60% of Medicare beneficiaries don't currently have access to these benefits. So this is, just a sum of our analysis to date. We plan on publishing these findings as well as some policy considerations to address some of these challenges that we just noted sometime later this year. And with that, I will turn it over to Matt Kazan at Avalair.
Great, thanks, Narda. Hi, everyone. My name is Matt Kazan. I'm a principal in policy practice here at Avalair Health, and I do a lot of work and spend a lot of time on Medicare Advantage and Part D issues. prior to my time at Avalier, I worked on Capitol Hill and was actually directly involved in a lot of the legislation that Michelle spoke at the beginning about changes to supplemental benefits. So it's been a lot of fun to dive into how some of these policies have been implemented on the ground. So I'll dive into a couple of our topics that we worked with. Thank you to the Playbook and the foundations for letting us display some of our work today. If we go to the next slide, I know a lot of my colleagues today are going over similar information, so I won't spend a whole lot of detail here on this slide about differences in offered benefits from year to year. We obviously did see a big jump in meals, in-home support, and over-the-counter benefits, and some other benefits as you'll see on this slide. But I think where I wanted to spend most of my time, starting on the next slide, is this issue and relationship between premiums and supplemental benefits and their availability and social risk factors. I think one reason why Congress policymakers look to Medicare Advantage as the platform to expand kind of non-medical benefits is you can do so in a way that doesn't directly increase federal spending, unlike in the fee-for-service world, where obviously Medicare is presumably would pay per service for these types of benefits. Supplemental benefits, as have been spoken to today, come out of plan rebate dollars and doesn't directly increase federal spending. Of course, one potential disadvantage of that is the amount of rebate dollars and therefore the amount of supplemental benefits that plans have is really a function of a whole lot of factors like fee-for-service spending, geography, plan bids, quality, star rating, plan premiums. And so we really wanted to dig into how do those factors relate to need for some of these benefits, social risk factors that potential enrollees have, and whether or not we're matching up some of the supplemental benefit flexibility to folks who may really benefit from these new types of benefits. And so we looked at a host of things, and it's summarized on this slide, and I'll dig into them more in subsequent slides. I think not surprisingly, we found that plans with the highest level of rebates are the most likely to offer $0 premium plans, and not surprisingly as well, that beneficiaries are smart and are attracted to those types of plans. One note that is interesting, and I'll go into this here in a second, is we saw plans that had lots of rebates, much more likely to offer a $0 premium plan rather than a host of a set of supplemental benefits. And so where this really does get interesting though is when we looked at the interaction between areas of the country that have social risk factors or certain socioeconomic factors and offerings of some of these supplemental benefits. And so I'll dive into those as well. If we go to the next slide, the first piece we looked at, was the relationship between rebates and premiums that plans offered. And so as you can see, we divided plans by the amount of rebates that they had. And as you can see from the left-hand part of the slide, plans with a large amount of rebates were very likely to offer $0 premium plans. And if you look on the right-hand part of the slide, you'll see that beneficiaries very much were attracted to those plans and disproportionately enrolled into plans with $0 premiums to the tune of about 4.2 million beneficiaries. This is a little bit opposed to high rebate plans using those dollars for supplemental benefits. If we go to the next slide, we conducted the same analysis where again we looked at plans by the amount of rebate dollars they had available, and you can see here the number of supplemental benefits that those high rebate plans offered was much more variable. You had a good mix of from 6 to 9 supplemental benefits. There was no clear direction that those high rebate plans went. And as you can see also on the enrollment piece, we didn't see this disproportionate enrollment of beneficiaries in high rebate plans that also offered supplemental benefits. So I think one kind of takeaway here is that at this point, beneficiaries are, obviously vote with their feet, and they're moving towards, or they are apparently more attracted towards $0 premium plans rather than supplemental benefit offerings. And so I think that is potentially an interesting lesson for policymakers and other stakeholders as they think about these new supplemental benefit flexibilities. If we go to the next slide, I think the second part of the analysis that I wanted to highlight was the relationship with areas of the country that have certain socioeconomic factors or social risk factors, and the availability of some of these supplemental benefits that are, from a policy perspective, meant to try to target some of those social non-medical needs. So we distributed the counties across the country by socioeconomic factors. We looked at income, education, access to a vehicle, and race. And then we looked at 3 specific supplemental benefits, meals, transportation, and telehealth, to look at how availability of those benefits related to the geographic and social economic factors in those geographic areas. So if we go to the next slide, we have a kind of summary of that analysis. And what you'll see here on the left-hand part of the slide is that you do see slight differences between what we've termed as disadvantaged versus advantaged counties in terms of offerings of some of these supplemental benefits. For instance, in the poorest counties and the counties with the lowest education, we do see slightly higher offerings of supplemental benefits. But conversely, in counties where we see the lowest access to a vehicle or the highest proportion of minority populations, we actually don't see a whole lot of differences between supplemental offerings. And so I think this does raise a potential question about whether or not the current MA policy is incentivizing plans to target these benefits to the folks who potentially benefit the most from them. The next couple of slides, we really dive into these specific supplemental benefits. So if we advance it one more slide, here we look at income. And income, the story directionally looks pretty good from a supplemental benefit perspective. We see in the counties with the highest proportion of households that live under the poverty line, we see more of these types of benefits being offered, though not huge differences. We do see directionally what you would expect. Enrollment looks slightly different, where we do see better or greater enrollment in those higher income counties. But I think most importantly, the offering is in the direction that one would expect from a policy perspective. If we go to the next slide, which focuses on transportation and access to a vehicle, there's a slightly different story. We look at counties that have near universal access to a vehicle. 40% of plans in those counties offered some sort of transportation benefit. In counties with less access to a vehicle, that percentage really only increases to 43%. So not a huge jump, even though we do have differences in access and you would think need to this type of benefit. Telehealth is actually flipped, where we see less access to a telehealth offering in counties with limited access to a vehicle. But unlike the previous slide, the income or the enrollment offers a different story. And we actually do see more enrollment, as one would expect, in plans that are offering transportation. So I think a bit of good news there. If we go to the next slide, we look at race. And we do see, when we looked at a proportion of population that is non-white, we did see slightly more offerings of meals and telehealth, but less access to transportation when you looked at it from the perspective of this racial makeup of the particular county. So again, some interesting questions. We have a host of data. I wanted to pull out just a couple slides here that I thought told an interesting story. I think the conclusions that we've drawn are at least questions that I think are worth posing as people think about the future of supplemental benefits and the future of this conversation generally, right? Policymakers have touted these new benefit flexibilities, as they should. These are the direction that I think a lot of folks want to go. I think there are some really interesting questions about how the current MA payment system works and whether it is properly incentivizing supplemental benefits generally, and really are those supplemental benefits being targeted in a way that's reaching the populations that should benefit the most from some of these non-medical services, which I think leads to the final kind of unknown, which was outside of the scope of our study, which is, are people using these new supplemental benefits? What are the utilization trends? And if they are what impact is that having on costs and on quality for those beneficiaries? So I think a whole lot of good stuff to come. I would expect from these types of research and my colleagues on the stage, so to speak, today. So appreciate the attention and happy to answer any questions. I think we're going to Tyler next.
Hi, thank you, Matt, and Narda and Michelle for all of the really great information so far. I'm Tyler Cromer. I'm a principal at ATI Advisory. We're a research and advisory services firm focused on transforming the delivery of healthcare and aging services for highest need older adults. So I'm going to spend some time today talking about the future of these benefits, which we think have a lot of potential to maintain or improve the health of Medicare beneficiaries, with a lot of caveats as Matt just laid out. Our goal in all of our work is to advance the implementation of these new non-medical benefits so that they are meeting individual beneficiary needs. So with that, I'll dive in. We'll go to the next slide. You'll see we have a lot to cover. So we're going to start with some information about the benefit offerings for plan year 2021. What do we know about how these offerings are changing heading into January in the new plan year? Then I'm going to spend some time talking about two new resources that we are announcing and releasing today. The first is a roadmap for plans and providers, and that's where we'll spend a lot of time. And the second is a policy brief with some recommendations and considerations for CMS and Congress. And then finally, I'll wrap up with some information about some guiding principles for the implementation of SSBCI. As Narda said, these benefits are a mouthful, so I apologize for that. But we put together with our colleagues at the Long-Term Quality Alliance and with support from the SCAN Foundation, a set of guiding principles for the implementation of SSBCI. So we'll talk about those a little bit too. So we will dive in on the next slide. This is a visualization of what CMS has released in press release about supplemental benefits in 2021. So as Narda mentioned, we are seeing some really substantial growth moving into 2021. You can see that the expanded definition of primarily health-related benefits, the number of plans offering those benefits is increasing by about 50%. You see increases across the board here, but really dramatic increases in SSBCI, these special supplemental benefits for the chronically ill, a fourfold increase in those benefits in 2021, which is the second year of implementation for these benefits. So we expected those to grow. This is really substantial growth. The reason the first picture here, it has a red box around it, is because that's the only benefit that we have information and data from CMS on for 2021. So when we go to the next slide, we can tell you a little bit more about what those benefits look like in 2021. So you can see, again, about 50% growth in the number of plans offering these benefits. Availability is certainly not nationwide, but we do see at least one plan offering at least one of these benefits in 42 states. And this map is colored more blue this year than it was last year. So we are seeing some expansion. And when we talk about these benefits, if we go to the next slide, you can see exactly what benefits we're talking about. This is a group of 5 new benefits that were first allowed in plan year 2019. And you can see here that home-based support services are really leading the growth. So you see in-home support services, the number of plans offering those more, almost doubling. You see home-based palliative care, the number of plans offering those more than doubling. And I think this is a reflection of plans recognizing in COVID-19, both in 2020 and in 2021, there's an imperative to keep members and individuals safe in their homes. And so I think you're seeing that reflected here. So we'll go to the next slide. Now that we have some context around what 2021 looks like, and as plans are actually beginning to think about what plan year 2022 looks like, we wanted to provide some insights and approaches to overcome roadblocks and bring new benefits to market. So we conducted some market research. We interviewed 20 plus Medicare Advantage organizations, providers, and beneficiary advocates. And the focus of our research was really what happens within a plan to go from having an idea about a benefit that's new and innovative and something that hasn't been done before to actually bringing that to market, implementing it, and then hopefully learning and iterating over time to improve these benefits. So we took what we heard and put that into 5 key steps outlined here, along with associated roadblocks and some really practical strategies to overcome those roadblocks. So on the next slide, we will dive in on step 1, which is about building support for offering these benefits within the plan. You know, this could probably go without saying, but a plan's not going to offer one of these benefits if the plan's leadership doesn't support the offering of one of these benefits. And so it's really imperative to build support within the plan. We heard a lot of strategies for tackling this roadblock. It starts with having internal champions, usually more than one person, who understands the value of addressing social determinant of health needs, understands the value of long-term supports and services and how that can better serve the individual and reduce healthcare costs. That person or group of people does the things that follow. So they identify the benefits that members want, the things that, you know, when you talk to staff or when you talk to providers, they say, gosh, we really wish we could provide this service. You know, if our bennies had more access to nutritious foods, we think that could really make a difference. So they identify those things people want and think can have an impact. And they do their research, right? They bring data and results to the conversation. Narda spoke earlier about, you know, there's some research in this space, but not a ton, and that can be a bit of a roadblock in and of itself. But these advocates, internal advocates, bring what data is available to the conversation. And the other thing they do is they test a new benefit or offering. This is we've heard a very effective strategy, and it's borne out in the data. We're seeing a lot of Medicare Advantage organizations offer these benefits in special needs plans, which other folks have talked about. Those are plans that are targeted to a group of high needs beneficiaries. And what we heard is that a lot of Medicare Advantage organizations are essentially trying out these benefits in those plans, and if they prove successful, looking to expand them to other plans. Next slide talks about step 2, which is about making that plan and provider connection. Again, you heard Narda talk about how a lot of these providers have not worked with Medicare Advantage plans before. It's a really intimidating environment. There are HIPAA compliance requirements. There are high insurance rider requirements, and that can be a bit intimidating. And the other thing that we heard a lot about is the mismatch between the plan service area and the provider service area. So plans often covering multiple counties, a whole state, going across state lines, and lots of provider service areas just don't match up with that. So this is an emerging marketplace, but we're seeing some emerging solutions in this space. We're seeing third-party entities step in and actually build provider networks and help with some of the compliance with contracts. So some examples of those organizations, we see Health Align working with home care providers. We see community-based organization networks like Partners at Home Network in California stepping in to fill some of these gaps. And we think that this is an area where third-party entities can really help. Moving on to step 3, and I should say There's a lot in here I'm not covering, but all of these resources are live on our website, and there's a link to them. So there's a lot more in the research, but also easy availability to learn more. So moving on to step 3, this is about designing benefits and developing the bid. So Medicare Advantage plans are putting in their bids in June of every year to CMS. In this process, we see those internal champions advocating for benefits, certainly. And the other thing that plans are doing is figuring out who can access the benefit that they're contemplating. How is this benefit targeted? And you have heard throughout these presentations, there's a lot of complex authority associated with these benefits. It's frankly a bit confusing. It can be overwhelming, but all of the different benefit authorities have different standards. And so one thing we heard in our conversations and research is that the SSBCI standards for eligibility can be a roadblock. Members have to meet a 3-part test to be determined eligible as a chronically ill member who has a high risk of hospitalization or other adverse outcome and who needs care coordination. And so some plans identified that as a roadblock. That's actually identifying those members is difficult, and it's either keeping them from offering SSBCI, or they're deciding to offer only in a special needs plan where a lot of that criteria has already been met for entrance into the plan. So the solutions here are around using a care manager to really identify and coordinate those benefits. And there's also a policy solution here around providing some clarifying guidance on that 3-part definition. In doing that, when CMS does that, keeping it broad to allow some flexibility and innovation. Moving on to step 4, this is the hugely important step of educating and implementing. You can complete steps 1 to 3 with perfection, but if no one accesses the benefit, it really won't matter. We all want members to access these benefits and to use them. This step is all about communication and education and a system to identify eligible members. So we provide multiple pathways plans can take to create these effective identification and communication mechanisms. Step 5 on the next slide is about getting better. So we're early on in the implementation of these plans. These benefits should evolve over time with learning. This step happens at both the individual plan or MAO, Medicare Advantage organization level, and it also happens at a system level across all plans. So we offer some approaches at the individual plan level to increase evaluation and improvement of these benefits, but we also offer a recommendation that plans share learnings through trusted and neutral third parties so that these benefits are improved across the board and we're raising all boats. So on slide 38, the next slide, we talk a little bit, so we've been talking about what can plans and providers do, less so about what policymakers can do. We are releasing a policy brief today with some recommendations, both in short term and long term. For CMS, we recommend some clarity and technical assistance on allowable benefits and that targeting criteria we talked about a little bit earlier. We too, like Narda, heard about there's some difficulties in communicating what these benefits are and aren't to members. So we do recommend some improvements to CMS marketing guidance and also to the Medicare Plan Finder so that beneficiaries have clear information about these benefits. And then we also just ask that that guidance be released a little bit earlier in the bid process. In the longer term, we think that this learning and sharing of learning is really important, and building in mechanisms for that learning. And then we also recognize that the dollars for these benefits are very limited. So it's important to think about the sustainability of these benefits and the appropriate funding structure moving forward. And then finally, on the next slide, I want to leave you with the work of this incredible SSBCI leadership circle that's made up of national experts from across Medicare Advantage plans, providers, academics, and beneficiary advocacy groups, because of the importance and the opportunity of SSBCI to address some social determinant of health factors. This diverse group came together and agreed to guiding principles for the implementation of these benefits. At the core, as you can see here, this core principle is that SSBCI should reflect individual member need, and it should move us closer to person-centered care. And then the supporting principles include that the benefits and how to access them is clear and understandable. That SSBCI be provided in a sustainable manner, so they're not changing, they're not whipsawing every year in dramatic ways. That they're provided equitably across the plan's members, and importantly, that they evolve and get better over time. And then you can see around this graphic the word collaboration, and that's really meant to emphasize that plans, providers, and the government all have to work together to meet the potential of these benefits. So we have some, like I said, more resources available. You can see the link on this next slide. I think, one message, if you can take away one message from this presentation today, these benefits are worth trying. They're worth evaluating. They're worth testing and iterating and improving over time to better meet beneficiary need. We think there is a huge opportunity here to provide services that have traditionally existed far outside the Medicare payment system. So we look forward to continuing working on these issues. And with that, I'm going to turn it over to Michelle.
Wonderful. Thank you so much to all of the great presenters that we just heard from. That was an incredible amount of information, and I know that we have and will have more really good questions to discuss all together. But first, I'm very pleased to introduce Dr. Sachin Jain, the President and Chief Executive Officer of the SCAN Group and Health Plan, to share his reactions and talk a little bit about his plan's experience with these new expanded supplemental benefits.
Thank you so much, Michelle. What an outstanding set of presentations, really insightful, really thoughtful. So thank you so much to Narda, Matt, and Tyler for really, I think, painting the broad national picture on these benefits and how they've been received in the marketplace. I want to take a big step back and just spend a moment talking about why plans introduce benefits, just from a tactical perspective. I think there's two primary reasons that plans tend to introduce benefits. One is whether they believe that those benefits will be attractive to potential new plan members or new beneficiaries from a sales perspective. So there is a constant evaluation of benefits through the lens of, will this help, Plan X sell to new beneficiaries? And then the second reason why I think plans introduce new supplemental benefits is whether they're going to actually make a difference, whether they're going to reduce medical costs, actually improve the experience of care for beneficiaries. And it's not surprising to me in that context that we've seen the lower adoption of these benefits that Narda articulated. Because these benefits are new, number one, it's unclear how they're going to be received by potential beneficiaries. And then number two, it's unclear whether they actually make a difference. I think there was allusion to the relatively thin evidence base around supplemental benefits and interventions around the social determinants of health. While I think there's a lot of interest and advocacy around these types of benefits, there's not a ton of evidence, as Tyler pointed out, that they actually make a difference. And so it does take the kind of leadership that Tyler referenced from people who are responsible for leading these plans, leading the medical management functions of these plans, or leading the benefit design, kind of product design components of these plans to actually drive these benefits into practice. I've been fortunate in kind of both of the Medicare Advantage plan worlds that I've worked in at CareMore as well as at SCAN to have people like Scott Reinfort and Jill Selby, who are truly innovative and trying to push the bounds of what these benefits could potentially do. But what I'll say is that there's still, again, a little bit of resistance, because there's always a trade-off when you're trying to spend those rebate dollars. Are you going to spend those rebate dollars on lowering premiums, to Matt's point, or are you going to spend those rebate dollars on benefits that may have unexpected benefit to the plan or unexpected benefit to the beneficiary? So I think that there is all of the observations that I think Narda, Matt, and Tyler made make a ton of sense in the context of the evolving and changing landscape. I want to kind of present to the group, a few things, a few concepts that I think are important for us as we go forward in this space. The first is this notion of integration, and I think Tyler referenced it. From a beneficiary perspective, if these benefits just kind of show up and don't connect well to the provider organizations that from which patients receive care, or to the plans, they actually have the potential to create more harm than good. If the benefits feel non-coordinated, disconnected, no matter how valuable the benefit may be on the surface of it, they may actually introduce more disjointedness for the member from a care experience perspective. So I think this notion of integration, connection to the experience of care is really, really important. It's something that needs to be front and center as we introduce new supplemental benefits. Number two is a notion of performance. We need to be very thoughtful about kind of dedicating precious Medicare dollars to these benefits with an uncertain view of whether they actually perform or make a difference. And I think we need to start to take a hard look at how we evaluate and rate these benefits and the benefit providers who operate in this space. Because what I can say is, when you look at things like non-emergency medical transportation and exercise networks that have been a long part of the Medicare Advantage program, the performance of these organizations is frankly really mixed. And I think many organizations don't necessarily fulfill the stated benefit that we're really asking them to fulfill. So I do think that there needs to be a high degree of attention and focus on ensuring that we are, like we do with Medicare Advantage plans through the STAR ratings program, implementing ratings and rankings and measurement programs that will allow Medicare Advantage plans to have clarity of with whom they should partner on actually delivering these benefits. I can say there's nothing more disappointing than entrusting the care of your members or your patients to a supplemental benefit provider who then doesn't actually value or honor that trust. And so I think that's a really, really important. And then I think there's a third point, and I think this goes back to one of the reasons why I believe these benefits have not necessarily been adopted to the extent that they should be, is that we actually need to know who will really benefit from these benefits. And I actually think that Medicare Advantage plans need to do more to actually get to know who they are serving and what their specific needs are. At SCAN, we have a very detailed, I would say, potentially overly detailed, but certainly a very, very detailed social needs assessment that we administer for almost every one of our patients. And what that social needs assessment allows us to do is understand what the specific problems are. And so now these new flexibilities that we have around targeting benefits are coupled with a clear view of who needs what, enables us to actually deliver what people need. And what I would argue is that many plans don't know what those needs are. And so when you see this gap between the needs that people have in the community and what's actually being delivered to them, it's not necessarily because, one of the reasons for that is because we don't necessarily actually know what those needs are. And so I think one of the kind of things that health plans need to do is take a big step back and make sure that they're doing the consumer insights work that they need to do to really understand who they're serving and what kind of benefits they need. And if they don't do that, you see some of the kinds of mismatches that Matt referred to around the populations that need these benefits and the populations who have access to them, which I think it was a surprising finding on the surface, but actually not surprising when you think about the fact that many plans don't know their beneficiaries really as well as they should, which I think leads to a broader observation about the MA industry writ large, which is, I think, and the health insurance industry writ large, if I can, kind of take a moment to think a little bit bigger, which is that we all need to be more clinical and more personal in our approach to understanding the needs of the individual patients, the individual beneficiaries, and then translate that into the types of interventions that ultimately are going to make a real difference. So really appreciate, all the very thoughtful presentations from Narda, Matt, and Tyler, and look forward to any questions that the listening audience may have. Thank you so much.
Thank you so much, Dr. Jane. That was great commentary. And again, I wanted to thank all of the presenters for their wonderful presentations. We are going to turn to the question and answer period. So I'd invite all of the speakers back on camera to address different questions. Thank you. Oh, wonderful. There we go. So we have a number of questions from our participants, our audience panel yet. So I think we'll start with those, and then we have a couple of more, and we'll see if more of those come in. The first question I wanted to ask, if anyone on the panel wants to address this, is about providers of these new services. Does a provider of flexible benefits for a Medicare Advantage plan need to undergo any separate certification by CMS to be authorized as a Medicare provider? Or does the credentialing occur through the sort of standard Medicare Advantage contracting process?
Michelle, I can help with that one, or Narda, do you? I'll start, and then Narda, if you want to add on. So, generally, not always, but generally, these benefits are being provided by providers who aren't, typical Medicare providers. So they're not medical providers, and there's not a Medicare certification for them. So you don't have to be Medicare certified to provide these benefits. What you are going to have to be, like the standards you're going to have to meet are going to be specified by the Medicare Advantage plan. And in some instances, for example, if you're a home care provider, you're going to need to meet the licensing standards of your state to be a provider. So that's the high level answer.
Great. And related to that question, another participant asked, how providers of these services, which are often community-based organizations, make contact with Medicare Advantage plans once they understand that that plan is interested in that services. There's usually somebody at a plan who coordinates working with these providers, and sort of thinks through the selection and implementation of benefits with those providers.
Yeah, I mean, I'm happy to answer that. I think, usually you have someone who leads product for these health plans, and they, manage the network of downstream providers. And so it'll either sit in the product function or the network function within the plans. So I'd be looking for either the product leader or the network leader.
Oh, sorry, I was on mute there. Thank you. Great. Any other sort of comments from your research about, anything else that other stakeholders reported based on their interactions between plans and providers?
Yeah, I can say a little bit about that, because that's something that we dug into quite a bit with the Medicare Advantage organizations that we talked to, as well as the service providers. And it certainly the decision making tends to fall within the product team lead, and that's the individual or entity responsible for making the decision. In terms of the strategies, in terms of which particular service providers that they seek out or contract with, that does vary quite a bit by plan. In terms of some of them, like we said, wanting to go with a more quote unquote trusted national brand that has a reputation that they've indicated they can trust. Some of the plans that we talked to indicated that they were getting contacted or reach outs on a daily basis from smaller vendors that may have more innovative offerings, but don't necessarily have that same brand recognition. Across the board, what we did here is, again, given the sort of limited evidence base in this particular area, those vendors that had more research, more robust data about their impact on ROI, on outcomes, on engagement, those points often helped facilitate the relationship, although they also indicated that they didn't necessarily trust just the vendor's data. That's something that they would always try to sort of verify on their own in terms of trying to really think about expected outcomes and ROI.
Great. Thank you. Question for Tyler and your presentation. It seemed to show that in 2021, plans reduced overall supports for family caregivers, which seems, counterintuitive given what's happening right now, given COVID-19 and the need to keep people out of institutions. So just wondering if you had any insights into that. And also, Dr. Jane, if you have anything to share about your experiences with family caregiver supports during this time, that would be wonderful to hear about too.
So that's a great question. And also something we, scratched our heads a little bit around. I think I would say not to worry too much about that number at this moment. And here's why. I think it's being driven by one carrier reducing a benefit that was like I believe it was like a support line that caregivers could call. So I think it's being driven by one plan or one MAO decision. So I wouldn't put too much weight in it. I think that, and I definitely would like to hear from Dr. Jane about this, but I think that plans and providers understand that caregiver supports are really important, and especially right now when caregivers are under even additional stressors over normal times. So I would say I think plans and providers are very cognizant about that, very aware of it, and I just wouldn't put too much weight into that one number.
Yeah, I would say I think there's a ton of awareness of the need for caregiver support. I think this field has really kind of blown open in the last 5 or 6 years. I think people have become increasingly aware of the epidemic of burnout, the so-called sandwich generation, people who are raising kids while also taking care of their parents, their aging parents. At the same time, it's unclear, kind of what is going to really make a difference, from a caregiver support perspective. You see things like respite benefits, which offer, kind of some in-home support. But, to be really honest about it, the benefits oftentimes feel inadequate for the task. If you have an older parent who's got, Alzheimer's, dementia, and, needs 24/7 support, and your health plan offers you 30 hours, you could blow through that in a week if you're not careful. And so, I think this is one of these areas where I think, we have to think more broadly about our social structure, our society. One of my big pet peeves is I think that there's a tendency in this industry to think that MA will solve all problems. MA will solve housing, MA will solve, caregiver issues, MA is going to solve transportation, MA is going to solve, every problem that aging adults have. And I think one of the biggest, needs is for us to take a much more targeted approach and really think about, where is a benefit really going to make a difference versus where is it just adding cost to the system because we're peanut buttering it across, so if you're offering transportation benefits to someone who has a car, you've already lost something. So, and who can drive a car? They may have a car, but they can't drive the car. So the point is, I just think we need to think more broadly about this, but also be a little bit kind of humble about what MA can and can't do.
One other point I would add to that, and Tyler, Dr. Jane, if you disagree, please jump in. But the other thing I think is important to keep note of is that these titles of these benefits are not necessarily the full description of what the benefit offering is. So like in-home services and supports, for example, in one plan could be very different than in-home services and supports in another plan. And it could be that caregiver support is part of a plan's in-home services and supports benefit in the coming year. So a plan could elect to rename a benefit and offer it under a different category, so to speak. We heard, for example, a lot of plans encompassing quite a few benefits, for example, under that social isolation benefit that we were talking about earlier. So it could be that some of the things that would typically have fallen under what we might think of as caregiver support are being offered under different category names.
I agree completely, Narda. And also that I would just say caregiver support in particular can be a very wide variety of things, ranging from respite care to a call line, and the number of hours could vary. And so I think that's a really important point. And then, Dr. Jane, on your point, we expect that from MA, and there aren't new resources either. So I think that's, something else that's really important, and we all have talked about in some way. But there were no new dollars for these benefits. So, if you look at what MA plans are spending, on average on A and B supplemental benefits, it's right over $20 a month. And so plans take really different approaches, from spreading that out in really marketable benefits, from that range to, if you target your top 5% spenders with really serious conditions, that $20 a month is a much more meaningful number. And so thinking about, what's that right balance is really important, because that number on its own is just not a very big number. So you have to be really thoughtful about how the benefits are structured.
Yeah, I couldn't agree more. And I'll just say, I think, Matt's data about, kind of the nature of benefits for people in low-income communities, it tends to be biased towards, buying down premiums and, making plans available at zero premium, as opposed to offering, the types of benefits that they potentially need. And so I think there's a pragmatic reality here, which is that, many people who will choose the, lower cost, plan with fewer benefits over the plan with more benefits, because at the end of the day, they're very price sensitive. You're talking about, kind of one end of the socioeconomic spectrum. And so I think it's just, really important to kind of, take into account some of these trade-offs that these unsavory trade-offs that people have to make around kind of, passing on savings in terms of lower cost sharing versus, not offering benefits that could really make a difference to people.
Thank you. That was a great, robust answer. And I have another question for everyone. I'm sure you'll have something to say about this that will probably elicit similar remarks. So this is based on a question that a participant asked, and I'm going to follow up on that with one of my own. The question is, has there been research done with the provider community to get their insights on what benefits are really being of value to their patients? So I'd love it if anybody wants to talk about that. And in addition, if you want to talk about generally what's needed to, assess the return on investment for health plans to provide these benefits. I think that, both in terms of determining what additional resources need to be allocated, like within plans too, what are missing data, what needs to be done to really make the case for the impact of offering these expanded services.
Yeah, I can start. I mean, we have not released anything publicly, but are definitely looking at studies or conducting studies related to utilization impact of A and B services based on enrollees who do receive certain supplemental benefits. I think one of the big gaps, Michelle, to your latter part of your question is CMS doesn't collect encounter data, utilization data of the supplemental benefit, unlike how they do with A and B services, physician services like that. So that is one big, I think, blind spot for CMS and for some policymakers. And so researchers who can either work with plans or work with supplemental benefit vendors, you get a little bit of insight into those utilization patterns of those supplemental benefits. And I think to the point that I think was brought up consistently today, we need better answers of what is the follow-on effect, whether it is lower cost care, lower hospitalizations, lower ER visits, for not only specific supplemental benefits, but specific populations that receive those supplemental benefits. So hopefully we can share more of that type of research at a later date, but there's certainly, from a CMS and maybe a congressional perspective, some blind spots.
And I can just share just from some of the interviews that we did with the plans that we were working with. in order to help generate some of that evidence base. And to your question, Michelle, about the provider partnerships, some of the plans that we talked to are either already or considering entering into value-based payment arrangements with their contracted providers that incorporate metrics on, collecting data around social determinants of health, or just sort of facilitating evidence generation around some of those criteria or things that providers have typically not necessarily documented. Plans are doing that, of course, to help inform their own evidence generation, and that data unfortunately likely won't be available to the broader public. But it does seem like plans are taking on initiatives to better engage the providers that they work with to be able to help facilitate some of that data generation.
So I will echo what Matt and Narda said. We can tell you all about the number of plans who are offering these benefits. We can tell you how many people enroll in those plans. We cannot tell you anything about the uptake of those benefits. We did hear anecdotally through our research process that that uptake, at least in some instances, has been relatively low this year. Don't think that's completely surprising given the year that we've had. Utilization patterns are nowhere near what we expected. Hospital discharges in Medicare fee-for-service were down, I think, 40% April over April. It's not a normal year. And so, I think there's a massive blind spot there. And then the other thing is that, plans don't have to share what they learn. So I'm sure they're collecting information and they're going to use that to refine the benefits. So one data point we're certainly going to we're going to start to see benefits, I think, rise to the top. And so we'll be able to tell from that the plans are assessing some value from the benefit. I won't be able to tell you if that's reduced hospitalization or utilization, or if that's increased enrollment, increased member loyalty, those sorts of things. But there will be a natural sorting process. We'd like to speed that up as much as we can by sharing information to the extent that it's practical.
Yeah, I mean, I'll just say I think it's actually easy to underestimate how difficult it is to do this kind of research. So when you think about the flexibility parameters of these benefits, you're talking about kind of real selection issues around who gets them, who doesn't get them, and so you're not sure, if the problem is with the benefit or is the problem with who it's being applied to. And so one of my big concerns with this space is the extent to which people in this industry tend to imply correlation equals causation. And we've got, lots of folks will say, oh, we're introducing a pesticide benefit. And, because of that, people got healthier this past year. There were fewer hospitalizations the same time we introduced a pesticide, the pesticide benefit. It's probably not the pesticide benefit that resulted in the lower hospitalizations this past year. It might be this small thing called the global pandemic. So I just think we have to kind of, and I will tell you, there isn't a chief scientific officer inside of most Medicare Advantage plans. And the benefit design is usually driven by highly thoughtful, engaged, non-scientific, well-meaning entrepreneurial product leaders. And so a lot of how we assess whether a benefit is doing well is whether the care managers tend to tell you that it's doing a good job and it's helpful to them in serving members, or whether the members tell you that they appreciated it, and whether the sales teams tell you that it's seen as valuable by potential enrollees. That's the kind of dialogue that's going on. There isn't this kind of engine. There isn't this engine of scientific evaluation inside of plans saying, well, we just introduced the pesticide benefit and hospitalizations went down. So.
And Dr. Jane, that's such a great point, because if you were designing something to test, it wouldn't be a benefit. A benefit has to be available to everyone, right? So there are ways to control for that, right? But this isn't being designed as a test It's being designed to get people benefits that the plan leadership thinks they need. So there's some tension here. It's something that that we think about a lot. Like, you don't want perfect evidence to be the enemy of doing really good stuff.
I totally agree, and I'm really glad you said that, Tyler, because I think that's really important too. Is like, we know that giving people some respite is good, whether it reduces healthcare costs or not. It's good. so I just think we have to kind of take both an evidence-based lens, but also balance it with a pragmatic lens, and look for evidence. For, I think, the stratification I would make is the big dollar items, where that are getting distributed to a lot of people should probably be the subject of a lot of research and inquiry. And then I think some of these other things we can evaluate over time, but I don't think we should be as hard on ourselves as we sometimes are.
It's a great discussion. Thank you. And now I have probably a very simple question for the data experts on the phone, which is there a source where one can obtain the names of the plans offering specific SSBCI benefits? Is that searchable or sortable?
So I wouldn't say that there's necessarily an easy publicly available source. So CMS does publish the data. They have the 2020 data is available for SSBCI. The 2021 data is not yet available, but it does require some, manipulation, programming, et cetera, to get it into a digestible format.
Great, thank you. And then another question more about sort of the operations of how these benefits work. How successful have plans been with providers of these benefits to submit claims through a claim system versus an invoicing system? Sort of what have been sort of successes and challenges with making that happen?
Yeah, I have to say, honestly, I'm probably the person who should answer this, but I don't have enough visibility into it. So I'm going to actually say I don't know.
That's fine. And perhaps this can be added to the list of more research questions that are needed, to see how these benefits work, which is, how do providers get paid, and how is that going, and what other education is needed between plans and providers. So thank you to the participant who raised that. Had an interesting question, again, sort of going back to the context of COVID-19, about social isolation benefits, and just, if anyone has opinions on whether social isolation focused supplemental benefits will become as valued as meals and transportation and dental and vision and sort of more traditional supplemental benefits as, we find ourselves in the situation that we're in.
I could speak to that just in terms of the organizations that we talked to. Again, every single organization that we talked to saw a lot of promise in that benefit. And it's not necessarily clear to me. There is one particular vendor that has been sort of found to be very innovative in this space that a lot of plans are contracting with. The thing that plans indicated is very attractive about the social isolation benefit, as I mentioned previously, is that the social isolation vendor first can be a source for gathering data, so helping to ask questions of the individuals that they're working with and finding out what other needs the individual might have in terms of food insecurity, housing insecurity, et cetera. But sometimes the social isolation benefit also includes some of those other services. So the individual who's coming to provide the social isolation benefit is also providing a ride or is bringing a meal. So plans are kind of looking to that provider as a one-stop shop, which is incredibly valuable, particularly with all the administrative and contracting challenges that we talked about, to be able to reduce just the number of organizations that they have to contract with to provide these benefits.
Yeah, so this is a topic, near and dear to my heart. When I was at CareMore, we launched, I think we were the first Medicare Advantage entity to launch a kind of a formal program in social isolation. We called it our Togetherness program. We saw tremendous promise in terms of engagement, participation rates in preventative screenings. We saw, a lower hospitalization rate, although there's some potential selection issues that we were trying to work through. So I think that there's a lot to do here. I think we tend to underestimate the profound nature of the epidemic of social isolation. My old colleague, Robin Caruso, would tell the story of one of our outreach team members calling a senior and getting the answer, hello, Armando. And the reason that she would get the hello, the answer would be hello, Armando, is because Armando, the health plan togetherness representative, was the only person calling this person, in the world. And so I think there's real opportunity here. The concern that I have, just looking at the landscape, is everyone's looking at everything as a big dollar venture capital opportunity. And we are making billionaires of people trying to solve these problems. And there's nothing wrong with billionaires, but I worry about the ethos. I worry about the ethos that we're kind of introducing to the Medicare Advantage program. The fact that we're commoditizing care, the fact that we're trying to solve big social issues, again, through a program like Medicare Advantage, where we can start to kind of chip away at it. And what I really think is we need a new social contract around how we care about each other. And I would just say, like, everybody who's listening on this thing, call your grandmother, call your aunt, call your uncle. Like, you don't need a Medicare Advantage plan to take care of your family. And so that's both a liberal and a conservative message all wrapped up in one. But I really believe that we need to kind of think differently about this, and it shouldn't be kind of the Medicare Advantage plan solves all problems, even though it's good that they are solving it a little bit.
I agree with everything you both said. I mean, I do think this is an area where we're going to see a lot of growth. The SSBCI data isn't out yet for 2021, but I think we're going to see a lot of growth in that benefit. And I think, there's the personal, and I think there's also this is a great space for community-based organizations, and I hope they'll step into it. This is a great place for villages. This is a great place for organizations that are about building community, and I hope that connection is going to happen too.
Great, thank you. We are almost out of time. We have time for one more quick question before we wrap things up. So sort of on that vein about specific benefits, last question is, are specific benefits you are finding that are most useful for members with dementia?
So I can't answer that question from our research. I think that's probably the boat that that folks are in, and why we're not answering is that's definitely going to be a sort of a more plan specific information that we have access to.
Yeah. Well, again, it sounds like that's something that I know is top of mind for most people in this space. So definitely something else that we should be looking at. I apologize for those questions that we did not get to. There were so many good ones, but we will be following up. We can follow up with people offline. And I'd ask if Travis could return us to the slides, and I can finish up here. So thanks again to all of the fantastic speakers who were with us today. I mean, really, this was a fantastic webinar. I learned a lot myself, and I really appreciate your time and dedication. I also want to thank the 7 Foundation Collaborative, and in particular, the SCAN Foundation, the Commonwealth Fund, and Arnold Ventures for funding this great work. I wanted to call your attention to the Better Care Playbook link. We are always interested in hearing about the good work that's out there, good research that's being done. Please don't hesitate to reach out and let us know about what you're doing so we can help to disseminate it. And then lastly, I wanted to remind you that there will be an evaluation following this webinar. It would be wonderful if you could please submit that. It helps make our work better, and we really do pay attention to all of the feedback that we get. So with that, I think we will wrap up today, and thanks to our great panelists and participants for joining. Thank you. Have a good rest of the day.